Everybody can see these slides. Here's information on the CMEs. I do not have anything to disclose, or nor do I have a financial relationship or arrangement related to any content for this discussion. So we are going to talk about harm reduction today, and this is just going to be a pretty quick overview. We're going to discuss sort of the conceptual model of harm reduction and contrast that with the abstinence-only model, and then also talk about some applications that are beneficial for using harm reduction with a substance use disorder population. And then I'm just going to introduce you very briefly to 3 core techniques and talk about how you could apply them. This by no means is going to encompass all of harm reduction, but it at least gives you a taste if this might be an area that you're unfamiliar with or have not used this model. So I like to start this conversation because harm reduction, for people that are not really familiar with it or use it all the time, like we do at ASAP, it can be somewhat controversial, or it can trigger some stuff for healthcare providers. So I like to always start this discussion by asking you to think about how you handle stress. So just to allow your mind for a moment to go to a really stressful, difficult day. I know we've all had those recently, especially right now in the holiday season and COVID and being overextended and pulled in a million different directions. So I'm sure we can all very easily go to that place where we're very familiar with stress, and then say, how might you handle that? Like, what is your way of dealing with it? Is it, going in and visiting friends and family, or doing a virtual call with them? Is it going home to the people that you live with and sharing with them? Is it, exercising or binge watching Netflix, any of those things, or even having a glass of wine or other things that are within moderation that help us manage stress, right? All of those things fall within the kind of normal curve of how healthy functioning people would handle stress. So what if you were trying to do the best you could to manage that, and someone just said, stop it. You're not allowed to do that anymore. Or they took it away from you. They restricted it. Or worse, they punished you, put you in jail for doing those things, for doing the thing that helped you manage your life, your painful emotions, the stress that you were dealing with. Or even worse, if you felt like a bad or broken person for engaging in that behavior, for doing the one thing that gave you comfort or made you feel less lonely, less anxious, less sad or afraid. Because that's really where a lot of our folks are at. It starts with a way of coping, and then it escalates to the point where it becomes its own very serious problem. But if we try to come at decreasing use from the perspective of just stop it, or can't you see these consequences, or can't you see, how this is hurting your family, your loved ones, it's not necessarily going to fix it, and it's not necessarily going to help them with the original problem, which is how do they handle life's difficulties, right? So I hope that gave you a moment of just compassion and connection for the folks that we're working with, that we're trying to treat. Because when we're talking about harm reduction, we're just wanting people to be as healthy as they can be, regardless of their use. So we're going to step out of that perspective. And the reason why it's important to consider these things is because we've treated addiction differently across time, and how we've treated it will impact the personal bias that we bring to the table and the stigma that the patients bring to the table. So over the course of time, we have viewed addiction as a crime. There's been multiple movements throughout history where we've punished people, put them in jail, restricted their movements, removed them from society, because we viewed addiction as this sort of contagion that would infect others, and they needed to be removed. That's still happening today. We still incarcerate numerous people because of either behaviors related to their use or intoxication. We viewed addiction as a moral failing or problem. So there's been lots of different movements of trying to treat addiction, saying that this is a failure of willpower, this is a weak character. There's even been thoughts about, well, people just have an addictive personality, once an addict, always an addict. And we know there's very, very little to no research that supports any of this, but yet this was a movement in how we've treated it. We've also treated it as a disease, and sort of saying that this is something that has a clear cause and effect relationship. So sort of if like with other diseases, like with cancer, if we can identify the cancerous cells and cut them out or irradiate them and get rid of them, then the disease will be cured. Well, we know that addiction is not that simple. It doesn't have a clear etiology that we can identify and just cut out or remove. And so what we have to adopt is what I think the truth about addiction is, that it truly is a complex, multifaceted condition. And so that means that there are going to be psychological symptoms, physiological symptoms, and social and environmental symptoms, and contributors for all of the above. And so we're not going to be able to identify one clear path. And that's why this idea of just stop it, or you know, expecting people to disengage from their use pattern prior to treating them is not necessarily the most effective model. And it's important that we really consider how we're thinking about addiction when engaging in harm reduction, because this is going to come up. This mindset that it's about motivation or willpower, the mindset that they just need to stop, is going to keep coming up. Even though we might think about it and read about it and talk about it all the time, it's so ingrained in our culture, in our society. So that's why I think it's really helpful to often remind yourself this is a chronic condition, very similar to asthma or hypertension or diabetes. It has multiple contributors, both lifestyle, genetic, personal choice, but you know, also early life experiences, exposure to abuse. All of those things contribute to the phenomenon of addiction. And how people will move through treatment looks very similar to these other chronic conditions. So medication adherence and relapse rates look very similar, and that we need to engage people in care and keep them in care in order to be most effective. So just like we would never expect someone to have, with serious diabetes, to have their blood sugar managed and regulated before we accept them into treatment, we can't have the same expectations of individuals with addiction, that they have their use behavior managed and under control prior to working with them. That in fact, in the course of working with them, to understand that those behaviors will most likely persist, or they will likely relapse, and that's just part of the condition. So why is this important? It helps us to understand that whatever treatment we're providing, it should be continuous rather than episodic. So we should be thinking about stepping patients up or down in terms of level of intensity, in terms of levels of care, but never really moving them to no treatment, right? That ongoing treatment at some level is probably going to be most beneficial for this condition. That the goal is not a cure, but just improvement. And so that fits really cleanly with harm reduction models, because what we're trying to do is help people be as healthy and functional as they can be today. So that might not include abstinence. And then recognizing that that is only one successful outcome, that in fact people can use in moderation, they can use periodically throughout the course of their life and still maintain functionality and health. And if that's the focus and that's the emphasis, then we're going to be in more alignment with a harm reduction model than an abstinence model. And that there's a lot of data that supports that harm reduction has led to substantial improvement in the use itself, in personal health and social functioning, and then of course decreased threats to public health and safety and monetary costs. So I'm going to show you where it fits in, and like we said, that continuous care is best practice. So understanding that patients are going to move up and down these different levels depending on where they're at, the severity of their use. Harm reduction is very helpful at the beginning of treatment, although you can come back to it at any point. It really does fit early on. And sometimes patients will benefit from harm reduction even before they benefit from motivational interviewing interventions, because we can do harm reduction with or without ambivalence. Remember that ambivalence is necessary for us to do motivational interviewing. And so if somebody's really pre-contemplative, they're not necessarily considering a change in their use, they might be open and willing to consider changes in terms of health behaviors. So if we can take it off, the focus off of the drug or the drug use, and put it on how can you be healthy and functional? What changes would you be willing to make in the service of that? That's harm reduction, and that is oftentimes the low-hanging fruit that you can hit right at the beginning of care. Versus in the middle, we're going to use some more what would fall under the umbrella of cognitive behavioral interventions, and that's to really help people start to cut down on their use, make strategic changes with their use, identify relapse risk, and then wrap it up with some solid relapse prevention skills and techniques. So what is harm reduction? Well, it really is a theoretical model versus a series of techniques. There are techniques that fall under the model, but in general, harm reduction is an emphasis. So if you think about it, it's almost like the spirit of MI. It's having the emphasis of collaboration, respect, so respecting that people are where they are, and really working to not judge that or be critical of that, accepting that they may continue to use at whatever levels they are, and that they can still make personal choices, working to empower them with compassion. So looking at what might be a skills deficit or what might be an area that they haven't explored that we could help them build up so that they can be as healthy and as removed from harm as possible. So that's really harm reduction. And we do this all the time as a society. So there are lots of things that you might not consider fall under this umbrella. So such as putting on sunscreen every day to prevent skin cancer, fastening your seatbelt every time you get in your car as a way to prevent serious automobile accidents, wearing bike helmets to prevent from TBI, and then medication-assisted treatments, right? Helping people to escape the cycle of intoxication and withdrawal. And that would even include things like treatments for nicotine. Things such as clean needle exchanges. So recognizing that while people are going to continue to use, let's remove the harm of risk for infectious disease, risk for abscesses or other things that would be associated with using dirty needles. So letting them have access to clean kits. And then things like safe or healthcare run injection sites. I know that we don't have this in New Mexico, but this has been a type of thing that's been supported in the harm reduction literature, that if people are going to continue to use, if we can provide a safe place for them to do that, where they can be medically monitored in case of overdose, where they're not going to be assaulted or robbed while they are intoxicated, that in fact that is reducing harm, and that's keeping people alive in the service of being able to engage with and access care. So if we can keep them alive longer, then we have more opportunity to continue to help them, because consequences alone are never going to be sufficient to shape behavior. And then finally, things like sex education or condom distribution or HIV and hepatitis C testing. All of these things fall under the umbrella of harm reduction. So some of our major goals in this model is to really just in general reduce harmful consequences associated with any high-risk behaviors. And you can apply that to, unprotected sex, driving without seatbelts, riding a bike without a helmet. So all of those things would apply. We're really trying to help people, and I think this is important, be safe and healthy right now. So that's another reason why harm reduction is so beneficial at the beginning of treatment, is because we don't have to wait for long-term change. We don't have to wait for major goals to be accomplished. We can define goals that they can act on today, Like, what could they do right now that would be one step towards health and safety? Because again, the longer we can keep them alive, the longer, the more opportunity that we have to increase their functionality over time, which will result in decreased use, whether or not we go directly after the use behavior. It's important under this model that we're not the ones forcing a standard or a judgment or setting up an unattainable goal that would put them in the position to sort of fail and give up. We don't want that learned helplessness. We want people to really feel supported, accepted, respected, and empowered to make a healthy decision today. So that's some of the difficulty with abstinence-only programs or models, is they can have, not in all cases, but they have the higher likelihood of coming across as confrontational or judgmental. And what we don't want to do is push people out of treatment or alienate them in a way that they're going to continue to engage in those high-risk behaviors without support, without decreasing harm, and the likelihood that they will encounter death, leave treatment, relapse without any safety practices is much, much higher. So this is an example that we show quite often that shows one of the harm reduction interventions of buprenorphine maintenance versus detox. And you can very clearly see in this study how striking it is between having people go without a harm reduction medication like buprenorphine, which is the top line. You can see they had 0 deaths and how long they were able to keep people in care, versus those that went without that medication. They were just detoxed from the use. So the use was not there, but they had 4 deaths and very low engagement, down to 0 in treatment. So that's pretty striking, a comparison between harm reduction and abstinence only. This is another one that looks at the impact on society. And so we talk a lot about the impact that harm reduction can have on community. And so this shows the difference before treatment and after treatment of methadone and its influence on criminal engagement. So you can very clearly see that once people are treated and they are pulled out of that intoxication withdrawal cycle, even while continuing to use, but they have another alternative for stability, they no longer need to engage at the same levels in behaviors of their addiction to maintain their use. So they no longer have to engage in those criminal behaviors in order to maintain their same level of use. And so it has not just impacts on the individual and staying in treatment, but can also very much influence the communities or the societies that adopt a harm reduction model. And then this one was a study that I often think is interesting to include, because this was where they're saying, okay, we recognize that people need access to buprenorphine or methadone as a harm reduction option. Switzerland decided to say for those individuals who methadone and buprenorphine is not successful for, they fail out of that treatment, they decided to do a trial where they would provide prescribed heroin. So this was their attempt to decrease the rates of infectious diseases and deaths due to overdose. And they implemented this in 1994. So you can see that their rates of death due to drugs and then deaths due to HIV infection were dramatically increasing over this 20-year time span. And then when they implemented the prescribed heroin, which was no change in use whatsoever, and actually giving them a pharmacologically pure source of drug, and then keeping them in treatment, monitoring them in order to provide that drug, they saw steady decreases both in deaths due to drugs and significant decreases in deaths due to HIV. So that's pretty stark of a comparison. If we change absolutely nothing in terms of the use behavior, but we're able to keep people in treatment, we will still see improvement over time. So I really like that this study highlights the benefit of the harm reduction philosophy. So recognizing that, that in this model, we have to acknowledge individuals who use substances, individuals with addictive conditions, are experts in their experience. So they're the only ones that can decide when and how to make changes in their life, that they have strengths that they can use in the service of positive change, and we can capitalize on that if we get out of the tug of war of the use behavior or trying to change the use behavior. We can align with those strengths and help them be functional even while they're using. Then in terms of substance use, we need to recognize that it exists in really complicated ways and often in complex social situations. So it is not as simple as just stopping. So going back to that first slide where I said, what if, you were asked or punished by engaging in how you manage your difficult life situations? It wouldn't be that simple. Then in fact, you probably engage in those behaviors with people in your life in complicated ways. You have a complicated relationship with that set of behaviors. And so substance use is exactly the same. It can be categorized along a spectrum of harmful consequences. And so we have to include occasional use or moderate levels of use in that spectrum. So now let's go into some specifics regarding techniques, and just to include what that would look like. The first thing that we would want to do is we would want to identify, when we're doing good harm reduction, exactly what are the connections and the relationships that people have between drug, set, and setting. And there are numerous ways that you can get this information. You could just go through, in your good clinical interview, collecting information about frequency of amount, what is it that they're using, type and quality of it. So what's the details of the drug, the information about the set, so their health state, what their relationship to the drug is, their history of the use, why they use it, their stage of change, and then the setting details. So where are they when they use, who do they use with, what are their stress levels in correlation to it, the quality of their support system, how do they interpret the use, because it could be that they interpret it as completely normal in their culture or their community, or they could interpret it as highly stigmatized, right? And be bringing in some of that internal stigma and shame and guilt around their use. So you could get this information in a good clinical interview, or you could do it in a functional analysis. So that's another one, but that's where we need to start in terms of being able to enter into some harm reduction techniques. So we need to have good ideas of the drug, set, and setting. Once we have that, then we can start having conversations around how they can reduce harm, whether it includes their use or not. And one of the nice techniques, and you want to be careful with this technique, it's called a decisional balance. You don't want to use this with somebody who's very clearly in a contemplative or even an action stage in terms of their stage of change, because we could potentially push them backwards. But if they're pre-contemplative, they're early in treatment, there isn't a lot of ambivalence about changing, this can give you a really clear idea of what to focus on. So you essentially just do a 4x4, and you have the pros and cons of continuing the behavior, the use behavior, the pros and cons of changing the use behavior. You fill that out. And so here's an example. And the one thing that's really important is you want to place a numerical value of importance on that thing, because it's hard to create a hierarchy, which is what you're going to do next. So you might say like, okay, I have a nice balance between continuing and changing, or maybe you have a ton on one side versus the other. Now, how do I really determine what's useful out of that activity? You need to put that numerical value, which rates the importance for the individual, not your importance, but the importance for them. So you can see that there's a number of 10s on here in terms of high importance. And so then you rank them from the highest number to the lowest number, and that gives you a hierarchy of need. So for this individual, stopping their use or decreasing their use is not number one. What's number one in this case is actually managing their chronic pain, building up their self-efficacy, right, to believe that they have the confidence and the ability to change, supporting what are their goals around their use, right? So that we don't even get to their use behavior until number 3. So that gives me a really clear direction that what's going to be most motivating and most helpful for this individual in terms of harm reduction is to go after helping them manage their pain first. Another harm reduction technique that's part of that drug set and setting information that you're collecting is to do what's called a functional analysis. And so this is another place that you can start to get a clear idea of what people would be willing to do or what they would be willing to change that may or may not include their use behavior. So you can do something like this that sets up, okay, what triggers their use? What are the thoughts and feelings connected to that trigger? What's the behavior that they engage in when they have that thought or feeling? And then what are the positive consequences and then the negative consequences? So again, we're sort of setting up that decisional balance related all the way back to a trigger. So that starts to give us a lot of information that we can have a conversation and intervene at any one of these columns. We could have a conversation about, well, what would they be willing to do today to be as healthy as they can be in regards to changing the behavior category? What could they say to themselves in regards to the thought that they're having that would be counter to that when that thought shows up? What could they do in terms of the trigger? Would they be willing to avoid that trigger? Or is there a way to modify that trigger? Or is there some behavior that they could do instead in relationship to that trigger? So this sets it up so that you can have a really rich discussion about a number of things. And you can also start to show the difference in terms of their thinking and how that influences everything down the line. This is just another one that's even more simple, that essentially sets up the situation with the thoughts and the feelings they're craving and then how they cope with it. And so what we're trying to intervene with harm reduction is what are they willing to do that's in the service of health. And then the last technique that I think, this also falls under the CBT relapse prevention category, but I think you can start doing right away with harm reduction, is high risk situation identification. And in my opinion, this really should be done with every patient every time you see them, is helping them think through what is the plan for this upcoming week or month to maintain health and decrease risk. So truly in the harm reduction umbrella is identifying what are the situations that are going to come up that are going to be very risky for them. And that could be physical safety, psychological safety. It could have to do with risk around their use or likelihood of using more than they normally would. And just identifying what is that situation and then what are the ways that they could handle it in the most effective means possible. And they need to have numerous options so they can have a flexible choice when they find themselves in that situation. So this is just one example of how you can do one high risk situation and all of the different things that could be done in support of it. So I know I'm right. I'm 2 minutes over. So I don't know if anyone has any questions before I turn it over to Dr.